Hello, my name is Edmond Cronin. I'm an associate professor of medicine at the Lewis Katz School of Medicine at Temple University. Welcome to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbites segment focuses on arrhythmias in COVID-19. Please note this presentation was recorded on May 6, 2020, and the information was up to date as of that time, but of course this is a rapidly evolving field. At the end of my presentation, you will see some additional resources and have the opportunity to contact me with any questions you may have. So first of all, you may ask, why is an electrophysiologist interested in COVID-19? Well, since the early phases of the pandemic, it's been clear that the coronavirus has effects on the heart through multiple mechanisms. First of all, it causes pneumonia and inflammation within the thorax, which can cause atrial fibrillation. Think about post-operative AFib after cardiothoracic surgery, for instance, as a corollary. And secondly, in some cases, it causes a hyperimmune response, and inflammation is also known to contribute to atrial fibrillation. And thirdly, there's now abundant evidence that it causes direct myocardial injury through a variety of mechanisms. Here's a CT scan on the left of a patient with regular community-acquired pneumonia, and on the right, a patient recently treated at Temple with coronavirus pneumonia. Note the similarities and the classical appearance of peripherally based multilobar infiltrates in this example of severe coronavirus infection. Now, community-acquired pneumonia is thought to result from viruses in about 30% or so of cases, depending on the population and the geography studied. And from prospective registries, we know that about 10% of inpatients experience cardiac arrhythmia with a much lower incidence in outpatients. And if you look at the risk factors for cardiac complications in community-acquired pneumonia, you'll see that age and a whole host of cardiovascular risk factors are there. And notably, all of these have been described as risk factors for severe disease and for mortality in COVID-19. Now, moving from all-cause pneumonia to viral pneumonia, and specifically influenza infection, which is perhaps the most comparable previous experience that we've had, although it's much less serious infection. We know that influenza is actually associated with an increased risk of atrial fibrillation, and that this risk is reduced by vaccination. So coronavirus would be expected to cause atrial arrhythmias, but let's explore the variety of mechanisms through which it causes ventricular arrhythmias. First of all, cytokine storm that sometimes accompanies this infection causes direct and indirect myocardial injury. Secondly, there is evidence of direct myocardial infiltration by the virus, although the extent and characteristics of coronavirus myocarditis are unclear and are something that we're actively exploring here at Temple. We know that there's an intensely prothrombotic state in many severe cases, and therefore the potential for microangiopathy likely results in fibrosis and scar, and therefore the potential for ventricular arrhythmias. And lastly, inflammation and direct viral invasion may cause plaque instability and myocardial infarction, which has been described with influenza virus, leading to acute coronary syndrome and therefore ventricular tachycardia and fibrillation. And there is already evidence that other viral infections can be associated with malignant ventricular arrhythmias. Here's an interesting study that leveraged a remote monitoring database to look at the occurrence of appropriate ICD therapies and correlated this with seasonal influenza activity. And as you can see, there was a definite uptick in ICD therapies that coincided with influenza activity. So what did the data actually show? So far, we've discussed what we might expect from other similar diseases, but what about COVID-19 itself? Well, it turns out that the data are quite sparse. There are a number of case series published from Wuhan, China, where this virus was first described. One of them, for instance, described arrhythmia in about 17% of patients. However, it did not define what these arrhythmias were in any further manner. Another similarly sized study suggested that palpitations were present on diagnosis or as a presenting complaint in about 7% of patients or so. And this is something that we have seen occasionally here. However, again, it did not characterize what these palpitations were due to. It did find that palpitations did not predict fatal outcomes, but we don't know whether these palpitations represented PACs or PVCs or VT or AFib. We just don't know yet. But again, something that's been actively examined. Another concerning study of 187 hospitalized patients, and these were patients who were a bit sicker, I think, than the average patient in the US. found that about 5.9% experienced ventricular tachycardia or fibrillation during the course of their hospital stay. And this was more common with increased troponin. It must be said that this was a population where about a quarter of the patients were intubated, and about 1/4% or a quarter of the patients died during the course of this observational retrospective study, and therefore it probably indicating a higher disease severity than we're necessarily seeing. Another very well done and again very concerning study comes from Italy, and this study correlated the number of out-of-hospital cardiac arrests in contrast to the year before. So out-of-hospital cardiac arrests in 2020 are in blue, and on the exact same day the year before, 2019, the out-of-hospital cardiac arrests are in the orange bars. And then the rate of COVID-19 cases is displayed as a red line. And you can see that there's a huge excess in out-of-hospital cardiac arrests this year versus last year. And that rise in arrests kind of mirrors quite nicely the coronavirus infections occurring in that community. They further subdivided it into different provinces according to which provinces were more affected and less affected by coronavirus. And there's a very clear correlation between the incidence of the infection and the increase in out-of-hospital cardiac arrests. And I think most cardiologists feel that there are basically at least two explanations for this. Number one, some of these arrests are due to coronavirus infection itself. Some of them may be respiratory arrests, some of them are cardiac arrests due to primary cardiac causes like ventricular fibrillation, ventricular tachycardia, as described. And then the second kind of amount of patients who are having out-of-hospital cardiac arrests, unfortunately, are patients who are delaying presentation or delaying coming to the emergency room, or perhaps just medical problems not being dealt in a timely manner because of the coronavirus infection, because of fear of getting infected, and because of overwhelmed hospitals. And those are patients presenting, for instance, with late complications, mechanical complications of MI, for instance. And even anecdotally, I don't know that there's been properly ascertained data published on this yet, but anecdotally, we're certainly seeing a lot of reports of mechanical complications of MI, which used to be quite rare in the current era of reperfusion, etc. I myself have seen a ventricular septal defect post-MI and a papillary muscle rupture post-MI, both in the last month, and those are things that one would not expect to see in a month, probably not even expect to see both in a year, even in a busy CICU in this day and age. Further looking at cardiac arrests, and this was a study on inpatient cardiac arrests, so in-hospital cardiac arrests from China, again, found 136 patients who had a cardiac arrest. 90% of them were asystole, suggesting that this was respiratory in cause, and indeed that's what the investigators found. Asystole and PEA both largely originate from hypoxia, for instance. Unfortunately, only 13% of patients in this study had return of circulation, and the 30-day survival was a pretty grim 2.9%. And of those 4 patients, actually only 1 had survival with a good neurological outcome. So this was really, truly grim. In addition to the poor survival data for cardiac arrests in this series of patients with COVID-19, there have been many discussions and much thought about the implications for healthcare providers who, of course, risk exposure to the virus when performing CPR, for instance, on these patients. And I think there's a general consensus that appropriate PPE is certainly necessary for this unfortunate situation. Switching from a kind of a grim note to maybe a more hopeful note, it is notable that the coronavirus pandemic has really spurred a lot of innovation in both inpatient and outpatient practice. And I'd just like to focus here on both inpatient and outpatient monitoring, but especially inpatient monitoring. We, along with other hospitals and other centers, have been using wireless cardiac monitoring technology, which electrophysiologists usually use in the outpatient setting to diagnose patients with arrhythmias. And we've been using this on the inpatient side to make up for the relative lack of telemetry beds when hospitals have experienced a surge in admissions, which has exceeded their capacity to place patients on telemetry. And this has facilitated care of patients and also appropriate cohorting of patients, because of course you don't want to mix known coronavirus positive patients with negative patients on the same telemetry floor, for instance. So this has been a workaround. And hopefully, we'll see further innovations in this field. There's been a recognition that the attention to patients in person by nurses on the floor, for instance, uses a lot of PPE and results in a lot of exposures, and that has resulted in bundling of care. So the nurse typically waits until several tasks are due, or tries to coordinate several tasks to be due at the same time before entering the room and using a set of PPE and necessarily, you know, entering the room of a patient who's positive. Hopefully also that will continue to spur innovation on the monitoring side of things, where perhaps patch monitoring and multi-sensor monitoring will take over from our current system of wired telemetry monitoring and wired saturation monitoring, etc., which is cumbersome and a little behind the times perhaps in terms of just what technology is available. So based on our experience here at Temple, having treated many hundreds of patients, unfortunately, the hardest hit hospital in Philadelphia region, what arrhythmias are we actually seeing in patients with coronavirus? So certainly we're seeing a lot of sinus tachycardia, as you'd expect, physiological response to infection, fever, etc. We are seeing as well, it must be said, a significant amount of pretty significant sinus bradycardia. Example shown here, especially in patients who are intubated or patients who are in the ICU. Now, it's often, of course, difficult to distinguish, is this necessarily a specific effect of the coronavirus, or is it due to things like saturations, for instance, which obviously can be very low in these patients? Is it due to the effects of sedation or the drugs that we use for sedation in these patients? Is it due to hypothermia, for instance, which we can also see sometimes in these patients as an opposite of fever as such, and that can lead to bradycardia as well. So a little unclear whether this is necessarily anything specifically due to coronavirus. We're also seeing certainly some amount of atrial fibrillation, which you can see in the third strip here. Again, and this is actively being examined, of course, but I would say that we're probably not seeing an extraordinarily high incidence of atrial fibrillation, even in the severe cases. So probably something in the ballpark of what we know is the case for community-acquired pneumonia regarding the data I presented earlier. This third strip also shows some complex ventricular arrhythmia. So you can see a triplet, in fact, 4 PVCs in a row here. And that is something that I must say we are seeing. We're seeing frequent PVCs, we're seeing complex arrhythmia, we're seeing non-sustained VT, and that is perhaps a cause for concern, and again, an indicator that coronavirus infection, of course, can involve the heart and does involve the heart and can cause a myocarditis, which would be expected to present with ventricular arrhythmias of some kinds. So here's just one case example. This is a 72-year-old gentleman with ischemic cardiomyopathy who was known to have coronary disease and known to have ischemic cardiomyopathy, but then was admitted with a non-ST elevation MI and underwent coronary artery bypass grafting. So due to his known reduced EF, he was actually discharged after coronary artery bypass grafting with a wearable defibrillator because of perceived risk of ventricular arrhythmias. And he presented with a shock from his wearable defibrillator, which you can see here, which was due to ventricular fibrillation, and was appropriately treated by his wearable defibrillator. On presentation, however, it was also noted that he had some symptoms and laboratory signs that were consistent with COVID-19 viral pneumonia. And sure enough, the CT scan did show, again, multilobar peripheral-based infiltrates, which are indicated here, and his nasopharyngeal swab was positive. So the question is, of course, is this a ventricular fibrillation event that was caused by coronavirus? He certainly had the substrate to have this event beforehand. That's why he was provided with the device that he was wearing at the time. However, given the data that I showed before, it's hard to believe that perhaps the coronavirus infection did not at least facilitate to some degree or make more likely this kind of event. So what are we not seeing so far? That's also important, I think, to discuss. And certainly I've heard some anecdotal reports of patients with AV block with concomitant coronavirus infection. Questionable whether this is actually related to the coronavirus or not. It's interesting that in a large study using the national inpatient sample, so an administrative database granted, but quite a large study of almost 32,000 patients, with a principal diagnosis of myocarditis, heart block is reported in about 1.7%. So again, one would expect, and this is not coronavirus myocarditis, but just all-cause myocarditis, of which at least some is certainly viral, or thought to be viral. One would expect to see some incidence of heart block in maybe more severe cases of myocarditis in patients with coronavirus myocarditis. However, I have to say again, after many hundreds, unfortunately, of patients coming to Temple with coronavirus infection, we have not actually to date witnessed a lot of AV block, and we have not implanted a new pacemaker device for something that is unequivocally due to coronavirus AV block in our experience so far. So it certainly does not seem to be a common event. Another thing that we're not seeing, thankfully, is torsade due to therapy. So certainly some of the therapies that were earlier posited as potentially beneficial in coronavirus infection caused QT prolongation. And these included antiviral medications, which were subsequently shown perhaps not to be effective, and also hydroxychloroquine, chloroquine, and azithromycin. Again, all of which are lacking in evidence base really to say that they are effective, but have been widely used in the absence of any other effective treatment. And there have been several studies that have shown that, as expected, yes, indeed, there is QTc prolongation from these drugs. And the QT prolongation is higher if you use a combination of hydroxychloroquine or chloroquine plus azithromycin. And that's been kind of unequivocally shown, I think, in these 4 published studies. However, we are not seeing, thankfully, a lot of torsade, which you might expect with extreme QT prolongation. And out of these 4 studies reporting over 400 patients, only 1 case, thankfully, of torsade. And again, that correlates, I think, with our experience where we have not widely used hydroxychloroquine here, but again, we have not seen torsade, thankfully, as a result of it. Just lastly, on the subject of prolonged QT, to talk briefly about your genetic cardiomyopathy patients and your inherited arrhythmia syndrome patients. So we've talked about prolonged QT syndrome. I think for patients with long QT syndrome, really the main focus is just avoiding QT prolonging drugs, just like we should do in general. Otherwise, there are really probably no specific implications of coronavirus infection for these patients, other than just avoiding QT prolongation. There are some rare LQT2 mutations that do lead to a fever-induced arrhythmias. Thankfully, those are rare, and that may be relevant for those patients. One syndrome where this is probably more relevant may be the Brugada syndrome. So this is known to be a syndrome which, of course, electrocardiographic manifestations are more likely when the patient has a fever, and events may be more likely when the patient has a fever. So this may be unmasked by COVID-19, first of all, and these images are from a case report already published showing exactly this anticipated kind of event where coronavirus pneumonia-induced fever unmasks a type 1 Brugada ECG. So certainly it bears upon us all to just keep an open mind about this diagnosis, of course, as it always does. The other thing is that patients with existing known Brugada syndrome should really treat fever very aggressively. So it's known that fever is obviously a common complaint in patients with COVID-19 pneumonia, and these fevers can be quite high. For patients with Brugada syndrome, they really should be treated aggressively. And it may behoove us to perhaps reach out to our patients with existing known diagnosis of Brugada syndrome and just reinforce that message with them. So the coronavirus pandemic will, of course, like anything, drag up and stimulate a whole lot of questions and a lot of investigation. And I'd just like to focus on a couple of future questions that may be relevant from an electrophysiology perspective or an arrhythmias perspective. First of all, of course, is what is the significance of atrial fibrillation in the setting of COVID-19? Will this recur? Should patients be anticoagulated? These are actually questions that aren't even settled for even post-op AFib, on which we rely purely on really observational data. However, taking all the data together, I think for kind of secondary causes of atrial fibrillation, as they're called, I think we can expect that any patient developing atrial fibrillation in the setting of COVID-19 probably does have a significant chance of experiencing further episodes of atrial fibrillation in the future if we're to extrapolate from other situations. And again, anticoagulation in these settings it's an unknown. There are some observational studies that are hypothesis generating, but there are no randomized controlled trials published yet, unfortunately. So that will remain a question as to whether it's appropriate to anticoagulate patients and for how long. Certainly a distinct consideration for patients with a high CHA2DS2-VASc score. Now the question is there a risk of delayed arrhythmias? We feel that there may be a delayed myocarditis or a delayed cardiomyopathy associated with coronavirus infection, and maybe then there's a concomitant risk of arrhythmias that may happen even after hospital discharge. So again, this is something that we're examining and hoping to develop some data on, so that can guide treatment for these patients. Will the myocardial injury that we are seeing in the hospital, will that be reversible, or will some patients be left with a permanent cardiomyopathy as a result of coronavirus infection? Again, that's an open question. And lastly, maybe just to end on a more hopeful note, hopefully the pandemic-induced innovations that we've seen in inpatient and outpatient monitoring and visits, etc., will be durable. So I'm very hopeful that maybe in a year or two's time, when we look back on this, I'll actually be still doing a lot of my outpatient visits by telemedicine, and the patients will be sending in their vitals that they have taken themselves at home, and they'll even be sending EKGs of various kinds that they've taken themselves at home. Those technologies are available, and largely we just needed regulatory hurdles to be cleared away, which they have been, in order to implement them on a large scale. Hopefully that will persist. And hopefully also, as mentioned earlier, we will move a little bit forward in the technology used for inpatient monitoring, where we'll have more of a move towards patch monitoring, or just more patient-friendly and more nurse-friendly devices than we currently use, where we can hopefully monitor multiple different signals from a single patch, which does not have to be applied and reapplied very frequently, but rather stays with the patient for at least some part of their hospital stay. So thanks for watching CVI Heartbites. These are some additional resources on arrhythmias in COVID-19. And if you have any questions for me, please email CVI's Executive Director at the email address shown, and questions will be sent to me. I'd ask you to please share this link with anyone who might be interested in the information. And of course, please let CVI know if there are other topics which would be of interest to you. Thanks for watching this Heartbites segment. For more information on CVI Heartbite segments, as well as other CVI educational programs, please visit cviphiladelphia.org or follow on YouTube or Twitter at CVI_Phila. Thanks very much.